I am Russell Edwards. I am an OBGYN. I practice outside of Fort Worth, Texas. People probably are asking, well, why are you here? I'm here today because I was asked to speak about kind of the special needs and parenting and preparing for puberty. In my practice, I see special needs kiddos, and when their parents come to me, I help them out, try to make that transition in terms of placing them on birth control pills, devices, things to help them make that transition into puberty when they're starting their menstrual cycles. Let me see. That is not what I was wanting. This is my daughter. As you've probably seen, she was just running across the stage here before the talk. But she is my shining light. She is the one that I truly am proud of. She is a wonderful, vivacious little girl. She enjoys swimming. She enjoys dancing. She enjoys being just a great individual. She's the sweetest thing ever. So. Part of what has come across my mind is that how are we going to make her life easier and make that transition when she does go into puberty, and what things can we do to help her out in her specific case with SATB2, and in the same sense, how can we help out all these kids, all these girls that are going to be transitioning into puberty. Puberty happens typically between the ages of 10 and 15. There's no reason right now to think that these girls will not enter into puberty at the same time as that everybody else does. But we have a few different kind of complicating factors, I would say, with bone mineral density loss, higher chances of seizure disorder. So we want to kind of tailor those medications to those individuals so that they don't have worsening side effects, have worsening of their seizures or worsening of bone mineral density in that sense. So, of course, this is my daughter, so that's why she's very comfortable coming and visiting up here, because Dad's up here. So, in doing my research on special needs education, really, I found a great resource. It's through Vanderbilt University, and it was a guide, pretty much, Healthy Bodies. It goes through sexual education for special needs. It talks about menstruation and young women and boys, for that matter, of becoming comfortable with their bodies and learning about themselves and being able to express themselves in a safe, happy, healthy way. There's a Healthy Bodies guide for girls, and there's also a healthy guide for boys as well. I know I sent all the boys out of the room to the other end, but it's very beneficial. And it's through that website that's present right there. The boys' website is a little bit different, but you can still manage to find it through that website. Preparing for puberty. Kind of these are the guidelines. This is what we're going to be talking about today. I want to make this as informal as possible. I don't want to come off as a stuffy doctor that knows all and is all. So feel free to stop me, raise your hand. Questions are appreciated. So kind of the topics that we'll talk about, the true experts are the moms and dads in this very room, the ones that have already experienced in it and have gone into it. Hopefully this will help out for those individuals that haven't come into going through puberty yet. What can we expect? What are options for birth control, management, and menses? Also, as I kind of mentioned earlier, what about the bone mineral density concerns? We know that through our clinical evaluations, that's one of the things that is going to be recommended is DEXA scans, looking at their bone mineral density, make sure that they're not having fractures. And what do these medications do with that? What are the options to give them the healthiest lifestyle and happiest lifestyle. Next, seizure activity changes with those medications, as I mentioned earlier as well. Risk and prevention of abuse. Abuse is a very important part of a special needs child, watching for the signs and symptoms. Also, hygiene maintenance. Hygiene is, as we all know, is changing diapers and managing and helping them to transition in their life into puberty as well. So, what can we expect? Most children with developmental disabilities enter puberty around the same time as their typical developing peers. And for those parents with older children, what age do you begin to see the signs of puberty onset? Does anybody have any children that have already started to SATB2 to enter into it out here? Sure. And that is actually, you will see the development of pubic hair before you start to see the initiation of menses. So she will also have breast buds that will also start to appear most likely before menses as well. So those aren't atypical. I wouldn't call that precocious, but still, it's still, from that perspective, it will be in that typical range for her. So, yes. Anybody else back here? Does somebody? Is there another one? Yeah, there is. Yeah, that would be great. I want to make this as interactive as possible, so that's wonderful. Question, and then we'll come to you next.
Hi, my daughter is 11, she's 13.
Okay. Okay.
And she recently just started her menstrual cycle.
Okay. Wonderful. Yeah, and that's very typical. You'll find that 13 is a very, very normal age for women to start menstruating. One of the biggest things for women when they start their menstrual cycles is actually their composition of fat. The more fat, adipose tissue that they have, that's when they... So you will see precocious puberty or precocious early onset of menses when people are obese, when they're overweight. So in that same sense, she's just a normal, typically developing individual right now at 13 years old, starting her menstrual cycle. So yes.
She was very thin. I mean, up until her 12th birthday, she weighed about 80 pounds. We've all seen her, she's as tall as I am. But we went to the pediatrician at her 13th checkup, and she gained 25 pounds in that
Yes.
year. That was surprising for me to see that much weight gain in 1 year. But that whole transition into puberty was, I think the whole...
Do you want to color? Yeah, for sure. It rings true. Exactly what you're saying is that weight gain is usually what will initiate menstrual cycles to be started in young women. So very much so. And part of what I'm wanting to get feedback to is that I'd like to know for myself, in the sense, what are other people experiencing as well? And so far, it sounds like it's a very normal, typical development for these young girls. So I'm going to kind of talk about some more aspects of this here later in the presentation to maybe give you some ideas what you can do to help with that change of life that comes along. So. Anybody else want to say anything? Questions? Perfect. Okay. The last little statement here is very important for all of us, is that along with just the physical characteristics that come along with menstrual changes and puberty, there are also some emotional changes too. You might notice that your daughters become more irritable, they become just more emotional, and those little cues just need to be watched out for. I think that is, just to pay close attention to your verbal and nonverbal cues that your children are having. So, okay. This is a very dense slide, but it is very important. It's what I deal with on a daily basis. My experience with special needs adults and young women that are starting menstrual cycles, their parents will typically come to me and they will say, is there a way that we can just stop their menstrual cycles? Is there a way that she can stop cramping from these menstrual cycles? And in doing so, these are kind of the options supported by ACOG, which is our college of, American College of Obstetrics and Gynecology. This is what we go off of and what we utilize. They have put together a committee opinion is what it really is, stating that these medications can be used for a majority of these issues. We just have to pay close attention when we're treating our children, and you will have to go to your physician. You have a question? Right. No stupid questions.
What I'm looking at seems to be a lot of birth control medication.
Yeah.
I recognize that a lot of it obviously is some like hormone. Oh, hi. Sorry, no, that's okay. A lot of it is can do some like hormone regulation, which is what I would assume.
Sure. Very much so.
My child's not going to be having sex to have any sort of
Right.
increased risk of having
So,
is it necessary to medicate them?
well, you have other options, but really to stop menses and to treat it in that way. You can treat it, if you are all right with having if she is all right with having menstrual cycles are not too painful, they're easy to clean in the sense of hygiene aspects, I think that it would be perfectly reasonable not to do anything. There are other birth control options, but in my sense, this is really not a birth control talk, but more of a hormone control to help with menses and decreasing menstrual flow and decreasing cramping and pains from that aspect. So, and you're exactly right. A lot of these are birth control options, and I don't want to give that impression that that's what I'm trying to saying that your daughters are going to become sexually active. It's not that in my intent at all. So. The first one here on the list are NSAIDs. NSAIDs are your typical anti-inflammatories, which are like Motrin, ibuprofen, Advil. If you take those on a regular basis with menstrual cycles, it can actually decrease the amount of painful menstrual cycles by really decreasing the negative chemicals that are released during the menstrual cycles. It is one of those non-hormonal options. It is not going to take the menstrual cycle away, by no means, but it'll help to manage those symptoms. If you are a person that takes Advil, ibuprofen on a regular basis, it does cause GI irritation. Your stomach can erode and have ulcers and that sort of thing. So somebody on this on a chronic basis may have upset stomach for sure. So is it right for whoever is having their menstrual cycle issues? It's to be seen. But and one of the concerns, as I kind of mentioned, is that it's not really meant for daily use. The biggest one that I have utilized is combined oral contraceptives. That is our typical birth control pills. And there are different ways to prescribe these. One is in the typical pill form where you get 3 weeks of pills that are active hormones, and they will cause them to have a menstrual cycle. The other way of possibly doing this is using it in a continuous form. The continuous form implies that you're going to be using the 3 weeks of active pills and then skipping the placebo pills that are usually in the back of the pack. Essentially not allowing your body or your child's body to have a menstrual cycle. It's been shown that it's been perfectly safe. It doesn't cause any repercussions. It decreases their menstrual cycles, decreases pains, and those sorts of issues. The advantage, decreased flow and extended regimen is very nice. So, question again over here. Yes. I'm gonna have you run, and then I've got another one here too. So, we'll get back to you. So, Yes, ma'am.
sort of been studying this just given our current situation. And are the oral contraceptives, I've heard, are not good for our kids just based on our bone density issues, or
So-
stopping their menstrual cycle is not a good idea for our children that have osteopenia or...
So there's two components to the estrogen, or there's two components to birth control pills. There's an estrogen component and there's a progesterone component. Progesterone component typically has been shown that it can cause osteoporosis. It can cause the osteopenia that we are concerned with. The studies that it shows that it has really caused that osteoporosis and osteopenia is when it's given in large doses. So coming down the list here to the depo-medroxyprogesterone, those are the depo shots. Those are very large doses of progesterone, and that's where the studies were shown that it does cause bone mineral density loss. Birth control pills have such a very low dose of progesterone that it's almost counteracted against that, because the estrogen component is very important in bone mineral growth. For instance, when people go through menopause, they lose all hormones altogether, and that's the biggest time in a person's life, in a woman's life, when she will lose bone mineral density, is because she has a cessation of estrogen. So the birth control pills, even though they have a low dose, those low doses of progesterone typically don't cause the osteoporosis that the high doses do. And then you're also counteracting it with estrogen as well, promoting that bone growth. So as I go through this list, I'll kind of point out what I feel is the best options, and then which are not going to be the best options for our children. So do you still have a question? Yes.
So in the studies that support the continuous birth controls, that's with no break,
Yes.
what ages were those done on?
I don't know about the ages. Typically, birth control pills should not be started until a year after they begin menstruating. The chemical cascade between the brain and the ovaries is very sensitive, and it can be altered if you start these medications early. Also, the other concern is that if you start synthetic estrogens early in their life, it actually causes premature closure of their growth plates. So it will stunt their growth as well if you start these at an early age. So you just have to be very careful. I usually recommend that young women start these birth control methods at least a year after they have started having menstrual cycles, just from the safety aspect of it. So, any more questions? Okay. Going back just to the combined oral contraceptives, estrogen component has been shown to be at risk when people have clotting disorders. So clotting disorders are where you can get a clot in your legs that can break off and go to your lungs. People with clotting disorders, you may not know until they've had surgery, or they've been in a wheelchair or immobile, really. Those are the times that you have to be very careful about creating deep vein thrombosis. Estrogen has been shown to increase that capability in certain patients with those clotting factor abnormalities. So you just have to be very careful. And that, in the one sense, if we have children that are immobile in wheelchairs or they have devices that are on their legs, we just have to be very careful to watch out for the development of DVTs along with that. And it may be a consideration that you may not want to start oral contraceptives if they are immobile that way. So, one second, I have somebody that needs to talk to me. I stepped on it. Oh, it came off here.
Yeah.
Okay, sorry. Hold that for one.
I knew it wasn't here. Yeah.
Okay. Perfect. Okay, thank you. So one of the other options, similar to a birth control pills and the combined oral contraceptives, are the patch. The patch is a very convenient option of getting both estrogen and progesterone combined method as stated above. It is essentially a patch that stays on weekly. It gets changed. So there's really no, it's less of a hassle to try if you're trying to make a child take pills on a regular basis. It is a convenient form. In a similar sense, it can be utilized in a continuous manner as well, is that typically you would have the pill or the patch on for 3 weeks and then remove it for a week, and you start up the new series of patches. The continuous way would be just as well, by skipping the placebo week when they typically have a menstrual cycle and entering into that new cycle by just skipping that week off. Also, it's the same as we talked about earlier. It's an estrogen component. I have a question back there. Yes.
I had a question regarding how do we determine, just as a woman myself, I struggled with which, based off of my hormonal needs.
Yeah.
What form of birth control was best for me to not make me even more emotional?
Sure.
So would you recommend our girls having some form of a hormonal test to then determine what would be the best option for them?
Typically, and you are a perfect example. I would say that half of the women that come into my office, they will start taking birth control pills, and then after the first month, they will call back saying, well, I had these symptoms. And so it's almost as a trial and error type of situation. There's no laboratory data that says that, oh, I'm going to have these side effects, or I'm going to have worsening cramping. Typically, there are a lot of different progesterone derivatives, and there's only really one estrogen that really is in all the different types. There's, I would say, between 50 and 100 different types of oral contraceptives out there. What I typically do in that situation is that I see how patients are reacting, and I tell them, please come back if you're having worsening of acne, if you're having hair fallout, if you're having too much nausea and vomiting, if your cramping is worse. Tell me all of those things, and then from there I can try different types of medications and try to tailor it to who they are, because not every pill works great for every woman. It is a situation of just trying one and then tailoring it to them and trying something different the next time that they come in. So yes, and it's going to be difficult from that aspect too, is that as parents you're going to have to watch that in your child. You're going to have to say, is this really helping them, or are they feeling worse on this? So, but be active with your gynecologist. Let them know what is really going on, and they should be able to help you out from that perspective. So, yes, you bet.
Would you recommend then giving the girls, once we start, like a multivitamin or even like a prenatal?
Very much so. The biggest thing, especially in women's health, bone mineral density is our number one key issue. Vitamin D and calcium are what I recommend for everybody. And those are the substrates really for bone mineral density. The multivitamins are great, but I think that the core ingredients for our young adults, and especially for our SAS kids, is the fact that their bone mineral density does need to be heightened. Everybody is, I would say about half the population is low on their vitamin D, and the other half is low normal on their vitamin D. Everybody can benefit from good vitamin D out there. So yes, I would recommend a multivitamin as well. So, but those are the most important parts of it. So the vaginal ring, it's essentially, vaginal ring, the patch, and the oral contraceptives, they're all very simple or similar. They all have that risk of DVT. The difference is that how you take them. There's the convenient methods. They can be used as continuous methods where you can skip menstrual cycles, and also in the sense of skipping that placebo week and then stopping menstrual cycles. And I think that has been the biggest thing when I've seen my special needs patients come in, that has helped them more than anything to stop stop their visits, and then they don't have any, they have less pains, they have less bleeding, they have less cleanliness issues. So from the parents' perspective, they thank me whenever we get them set on that kind of situation. Progesterone only pills, it's listed here. It's not one of my favorite. It is a progesterone only. As I spoke earlier, there is more of a theoretical risk of that bone mineral density loss in progesterone only birth control pills. The very disadvantage of this option is that it does cause irregular bleeding. And if you're still having bleeding, you're still going to be releasing these negative chemicals. So a lot of people will complain about cramping and pains despite their cycles being less flow. It just doesn't fix it 100%. So I would leave this, on the lesser side of my list of what to utilize for our kids. The depomedroxyprogesterone, as I was stating earlier, this is the one where the studies were done that showed really a significant bone mineral density loss. They did not measure fracture risk or that. What they did is they placed them on 6 months to a year and measured their bone mineral density during the time that they did that. And once they stopped the depot shots, their bone mineral density returned back to normal. Really, it works by decreasing the amount of estrogen in their systems, and that decrease in estrogen is really what causes the bone mineral density loss. It's a very convenient method. As you can see here, you give it 4 times a year. It's every 3 months shot. You have the patients come back. They simply get a shot, and it works very well from that perspective and taking away their bleeding eventually. It does take a little bit of time to get into their system. Usually they have 1 to 2 months of irregular bleeding, and then they will notice if they continue to take the shot, it will continue to disappear. Progesterone IUDs. There are IUDs out there that have been indicated for abnormal uterine bleeding. Patients that have heavy menstrual cycles, and it is a progesterone-based IUD, meaning that, well, let me explain what an IUD is. An IUD is a T-shaped device, small, about 2 centimeters in height, 2 centimeters in width, that gets placed inside of the uterus. And it uses very much a local effect in releasing progesterone to thin out the lining of the uterus. When it's on a daily basis and it's very local, it can cause cessation of menstrual cycles as well. There are 3 different brands or 3 different modes out there. There is one that it has a higher dose of progesterone in it, and it does a very good job of taking away the menstrual cycles. There's a new one that has been on the market for a couple of years, and it's not indicated for abnormal uterine bleeding, but it has about a quarter of the amount of hormone. So you see a lot less side effects with that one. And it's typically one that we give to younger women because it has a smaller insertion size, along with the fact that if they're not having problems with their menstrual cycles, it just keeps them on a normal base, and it does lessen them, but it has a less incidence of completely taking their menstrual cycles away. And that one, the first one that I spoke of is called the Mirena, and it's the higher dose. It has more typical side effects. So there is a concern of bone mineral density loss, but I've always described it as that it has more of a local effect since it's being placed inside the uterus and you're sloughing off the endometrial lining right there. Then you're not going to see as many of these side effects from that. But now they have even this a lesser hormone, and it will control menstrual cycles, but it may not take it completely away. It's not listed here strictly because it's only really a birth control, but there is one more IUD. It's a copper IUD. It's not really meant for treatment of menstrual cycles and to decrease cramping with those menstrual cycles, but that's a Paragard. Really, strictly my talk is really to decrease menstrual cycles, menstrual flow, and decrease the pains that are associated with it. So that other IUD is not really part of that. Yes? Here, why don't you grab this? Yeah.
Hi. With the progesterone IUD, when we're thinking about concerns about bone density, my understanding has been what you just said, that it's the local effect.
You're very.
So, what, in your opinion, do you think is the realistic risk as opposed to oral progesterone for bone density?
Sure. In thinking about this, I think that it's kind of a risk. You have to weigh the risks. When you look at how bad somebody's menstrual cycles are, I take a short history. I try to figure out how many days they're bleeding for. I try to figure out how irregular their cycles are. And that's how I tailor the medication. I like the fact that this new progesterone only is a quarter of the amount of hormone, and it decreases their menstrual cycle. So in essence, the less medication you can utilize is really going to be the most beneficial, especially in this situation. In thinking about the protocols or how I would manage our children with SAS and their propensity for bone mineral density loss, I would monitor their DEXA scans probably biannually and see what they are at baseline, see what their bone mineral density, and then see if this option would be a good option. If after a year and they had no more bone mineral density loss, I would say that it would be a perfectly great option. I think that that's how to monitor it. Typically, we don't do DEXA scans on typically developing adults and children. Not until the age of 65 is it actually truly recommended. So it's hard to know what these progesterone-only local effect ones will do to bone mineral density. But it's very easily to be removed. The trick with IUDs is that how well are our young children, and as they enter into adulthood, going to tolerate pelvic examinations and bimanual examinations to do these? The IUD is, and I have placed them under anesthesia. It's a simple, you take them to the operating room, you essentially do their examination under anesthesia, and they don't even have a recollection of having it placed. It's not really painful in that sense, but it just is the inconvenience that you have to take them to the OR to really place these. It is expensive. It's always about, kind of the lifestyle changes. The birth control pills are kind of, in my opinion, one of the more ideal ways to go on a continuous basis. They're inexpensive, and if they're easily tolerated, then you can continue on with that method very easily. But there's going to be some children that are not going to be able to take pills, and then this is kind of my next best option when it comes down to it. And it is a one-time. These IUDs are good for 5 years, so their expiration is wonderful in that. So it's you don't have to do it on a regular basis. Questions? Yes.
If you were going to take the oral contraceptives without
The placebos?
placebo week,
Yeah.
are there any concerns about increased risk on? Sorry, is this no?
You got to do both.
It's not working. Okay. Is there any increased risk in malignancy later on, like breast cancer?
No, there is not. Actually, breast cancer, it is considered to be somewhat, not completely protective against breast cancer. And also in terms of ovarian cancers and endometrial cancers, they are both protective against that. The number of times that a woman ovulates actually increases the number of it increases her chance for ovarian cancer. In the same sense of using combined oral contraceptives, if you're keeping the endometrial lining at a very thin, regular amount, then that's not a high risk for endometrial cancer or cancer of the uterus. So really, from that perspective, these are protective against it in that sense. What you really worry about are these individuals from the endometrial cancer side of things that their lining becomes very thick and they have no menstrual cycle. In this sense, we are creating no menstrual cycle by keeping the endometrium very thin. And it's really that thickness of the endometrium that you would be concerned about. So, okay. Question back here.
I know some meds you can crush and some you cannot. So with birth control pills, do you have any ideas or any issues on crushing?
So, good question. Good timing. You can crush birth control pills. Those are fine to crush up and place into cookies or whatever. The one, there is a, it kind of sounded ridiculous to me, but there is a chewable birth control pill out there, and that's the name of it was Menastrin. I'm sure that there are going to be other options that will be chewable, but you can crush them as well. So.
Okay. And then another question that I had in the beginning, you had touched base briefly on seizures.
Yes.
Are you going to touch?
I sure will. Yes. Just briefly. Yes, I will. So. Other questions? Okay.
There's been a lot of questions in regards to birth control pills. So my initial instinct when I'm reading this is that a hysterectomy seems extreme, but maybe it's not. But that's my first initial instinct.
Sure.
I mean, what are long-term, other than obviously there's no children, but like are they at an increased risk for anything if they have hysterectomy at such an early age?
Yeah. And surgical is definitely after you've tried all your options. If you've run into so many problems and you're still having heavy bleeding, there's probably a few instances, that it's not just related to normal puberty, but if somebody has a fibroid uterus or they have a condition called adenomyosis or endometriosis, those are the situations where you really have to consider the extreme. So to say that somebody needs a hysterectomy at their young age, I would really encourage the doctor to utilize all medicines that are available to them before going that direction. I think that this is taken off of a website, and really it's last on the list because it's the last thing that I think of in treating young women, and it's after they've battled it for a very long time that a hysterectomy would be an advisable thing to do. So, and in the same sense, I'll quickly talk about that. An endometrial ablation and hysterectomy are both surgical options. The ablation is essentially where a device is placed inside the uterus and the lining of the uterus is scarred down. So they're not able to regenerate the endometrial lining, and it essentially scars it down. It decreases the amount of menstrual flow, and it also decreases the negative chemicals that are associated with menstrual cycles, decreasing pains as well. So between those two options, the tough thing is that these are really not intended for young adults. It's more when you have exhausted all efforts to treat them medically. The last one I did not talk about was the implant, and I'm not a huge proponent of the implant in special needs adults. It is a very convenient method. It's a small little rod that secretes progesterone hormone. It's placed in the left or right arm, and over time it lets off just progesterone to prevent ovulation. The biggest issue that I have with this is patients come back and they say they have irregular bleeding. And in this talk, my goal is to decrease the amount of bleeding that these young women are having from the cleanliness aspect, from the pain aspect, just to let them transition into normal life with being as healthy and normal as possible. So, okay. Well, I'm going to move on to the next slide. Does anybody? Yeah.
Sorry, I'm gonna sound like a broken record here.
Okay.
But, with the hysterectomy, you had mentioned earlier that when women go into menopause later in life, that's when they see a lot of bone density start to deteriorate. Do you think that would happen with a hysterectomy as well, or are there other things that are complicating for that?
Yeah. So from the perspective of, yes, every individual going past the average age of 51 is menopause. Will have a certain degree of bone mineral density loss. Say if you got to that point in your child's life, they were in their 30s, and you've exhausted all your medications. A lot of time I counsel my patients about removing their ovaries. Their ovaries are very beneficial. They still produce estrogen. So for somebody, I usually don't remove ovaries, or I counsel patients not to remove their ovaries unless it's absolutely necessary. And then if they're perimenopausal, if they are close to that age of 50, that's really where I would say that it's probably to your benefit. But studies have shown that the likelihood of ovarian cancer is not significant enough to where you need to remove those ovaries at a younger age when it's still producing good estrogen for that bone mineral density. So from that perspective, yes, I would individualize my treatment, and in most cases, I leave the ovaries in place when I do hysterectomies. So, yes. Any other questions? I'm running out of time. So this is kind of what we've already discussed, but I'm just going to read this off. Potential non-contraceptive benefits of cyclic estrogen and progesterone contraceptives. In the sense earlier, this is really a talk, this is what my talk is about. It's not for birth control purposes, but reduction in menstrual pain and decreasing endometriosis. Endometriosis is a complicated gynecological issue, but these birth control pills, contraceptives, can help to decrease those pains that are associated with endometriosis as well. Reduction in blood flow during menses with improvement in their iron deficiency anemia. Reductions in symptoms of their premenstrual syndrome. PMS is a common understanding when right before a menstrual cycle occurs, there's more irritability. There's a lot of these negative chemicals that are released from the uterus, and in doing so, being on continuous and even birth control pills can decrease those symptoms as well. Reduction in the risk of benign breast disease, and it actually shows the reduced risk of the ovarian cancers, as we spoke earlier, including some hereditary forms such as the BRCA genes as well. Reduction in endometrial and colorectal cancers, reduction in acne, and then it creates a more regular menstrual cycle for these women so that they can expect when to have a menstrual cycle, and then also decreasing it in intensity and pain. So on our bone mineral density concerns bone mineral density issues are a major concern for our SAS children and adults. As we've already found out that these genes have, for one reason or another, caused bone mineral density issues. And as I spoke to you earlier, progesterone-based birth controls may not be the correct choice to help out with their menstrual cycles because it may put them at further risk. So need for monitoring is very, very necessary. I believe that if any of our young kids are started on birth control pills, IUDs, I believe the DEXA scan and continuing to follow them every other year just to make sure that they're not decreasing in their bone mineral density is going to be very important. So this was just a screen to highlight, what we're thinking about for our kids. The other is, mentioned earlier, is seizure activity changes. There's an increased risk of drug-to-drug interactions between anti-seizure medications and hormonal contraceptives. The older medications, the older anti-seizure medications can cause what's called hepatic enzyme induction, where it increases and accelerates their metabolism, and then it alters the binding capacity of estrogen and progesterone medication, which can reduce the efficacy of OCPs and progesterone-only pills and implants. In that efficacy, if you are on medication and it is working to decrease the menstrual flow, the menstrual pains, that's very ideal. In what you are truly worried about is when they are on anti-seizure medications and you're worried about pregnancy. So this one doesn't make as much sense. They're still going to be able to utilize the medication. It's just that from the birth control side of things is that it's not as effective. And I know that doesn't matter as much in this discussion, but just as a thought. Also, plasma concentrations of lamotrigine are reduced by oral contraceptives. So whenever you consider it, if you were doing it as a typical birth control pill, taking it 3 weeks and then 1 week off, the week off causes an excessive amount of lamotrigine in their system, which can cause excessive side effects and really where the medication level is not where it's supposed to be. So in that sense, it's actually recommended to use it as a continuous dosing as well. Continuous dosing should be advised as drug concentrations can increase dramatically during that 7-day pill-free interval as well. So I'm going to move on next to the next slide. Does anybody have any questions about kind of those? So in talking about transitioning into puberty, as we've all learned, is that our kids are hard to keep clean. The very number one thing that we have done is enforce toilet training. I think that will make our lives easier in the long run. But the familiarity that they get from knowing that pee and poop needs to happen on the potty and not in their diapers, it's a transition for everybody. All these children are completely different, so it may take a very long time. It may never happen, but if you can institute and start teaching now, the sooner the better. In the same sense of their menstrual cleaning as well, these young women will have menstrual cycles, and if they're familiar with going to the bathroom, they will be familiar also with changing pads or in some cases tampons. I can't imagine that, but in that case it is a possibility. Also, familiarizing these kids as they transition into puberty by having them clean their own bodies, to familiarize and say, wash your bottom, make sure you get everything. And all these teaching aspects are very important for us as parents to make sure that they can sustain and to do these things on their own. It makes our lives easier and it makes their lives easier as well. So it's very beneficial. Hair trimming to make cleaning easier. If it's a common practice among special needs families that their children use hair trimmers to kind of cut down on the amount of difficult cleaning situations. So it's not uncommon to do this and just to promote it if that's the issue. And uncleanliness can lead to gynecological infections such as urinary tract infections and also vaginal infections. And it's in knowing your child, most of you change diapers and you know their anatomy, and but sometimes to be cognizant and to be understanding when they might have a urinary tract infection, they might be grasping themselves as if they're hurting. You also might notice that after they void and go to the bathroom, that they might have darker urine that has a foul odor. Also, vaginal infections. There's two kind of typical infections that I always counsel patients about, and yeast infections are discharge and also itching. So if you notice on their genitalia that there's scratch marks, and you've also noticed that your daughter has done that, then you might need to see a gynecologist about treatment. Also, there's also some normal infections that can occur as well, and those typically can cause lots of odor. So if you notice a lot of odor that's not going away, if it's just one day, it's not not worrisome. But if it's several days in a row, you may need to have some tests done just for so that they can get treated and be comfortable. It's very difficult in our group of children in the sense that they're nonverbal. So you have to take all their nonverbal cues and put those clues together to figure out what's going on. But being attentive and cleaning and teaching is very important. Does anybody else have any other ideas about, hygiene aspects? Okay. Lastly, on here, I've talked about, this is the website of that Healthy Bodies girls website that can, it's very beneficial. It's a guide. It's wonderful. And it's for boys and girls. Yes, question back here.
So you briefly talked about tampons versus pads, and I think you might have mentioned both. Okay. I feel like that you were leaning towards pads and couldn't imagine tampons being used. Am I correct?
Well, I think that the unfamiliarity with these young girls placing something vaginally in themselves is going to be a battle. It's going to be a challenge to teach them and to understand that that's part of their normal anatomy, and that's going to stay in place. Yes, it's a very good possibility that you could do that. I think that from the pad perspective is probably an easier manageable one from our parental aspects. But
and from, I know there's not a lot of concrete evidence, but there's definitely a lot of studies showing long-term care and abuse later on in life. And do you think that the introduction of tampons could stimulate to a point where that could be a concern to where a child with special needs would not be able to defend themselves in a situation?
Not at all.
Or anything like that?
Yeah, not at all. I think that if you are teaching your child about their own personal anatomy, in a non-sexual context, I believe that these young women will understand, and they will eventually. I don't believe that it'll lead to anything negative in that perspective. So, I think it's very important as parents that we are honest with our kids. We teach our kids. We don't want to neglect that. It's very important that we teach them about themselves, and that's what this guide is very much about, is that we have to be advocates for our children in teaching them. And then also it goes into sexual abuse issues, risk and prevention. Special needs children and adults are at risk for increased risk of neglect, physical, sexual, emotional abuse. So all things considering, that manual is very good. So that's just kind of highlight the rest of it. So that's going to be the end of my talk. So yes, I got a question over here. I spent a whole hour. Goodness.
It's not really a question. It's more of just some experience.
Yeah.
I started early. My daughter's 13. I was very concerned about this. A lot of anxiety. One, she did not like blood, but she cut herself. She was very sensitive to that. So I was in a very
anxious state.
Anxious about it. She actually handled it a lot better. There's a couple of other books that I would recommend. They're from the American Girl. It's called The Care and Keeping of You, and they come in different stages. There's like a 1-level book and then a 2-level book. They talk about all kinds of things related to personal hygiene, about changes in your body, all different kinds of things. And they're good books for the girls to look at also because they have great pictures as well as just little areas. There's also one about keeping friends and things like that. And they're good resources for parents to talk about with their kids. The other thing is that our schools, where we live in Maryland, have a curriculum where they actually do in 6th grade, 5th and 6th grade, they do a kind of a human kind of like a health class, and they talk about all types of things, as well as they give out a little packet of like a little pouch with information as well as pads and supplies for their for the girls.
For the young girls,
yeah,
yes.
and they also do it for boys as well. So there are other resources kind of out there.
Yes.
In addition to that, you can do it. I mean, it's very difficult.
Yep.
But it's not insurmountable. It's just like, teaching them to crawl or helping them to walk or anything
Sure.
like that. It's just more time on your part. So anyways. So.
Yeah, well, thank you for your wonderful
Sorry.
comments. Yes,
Yeah.
that's great.
Sorry.
Yeah, I think that from my perspective, I've got a 4-year-old. She's nowhere near that yet. So as I think about it, it's going to be it'll be a daunting task. But it can be done, and just like any other battles that we've faced, there's lots of resources out there, and I'm just here today to kind of share with you a few of those insights. So, all right, does anybody else have any other questions? Awesome. I think is it lunchtime yet? Hey, sweetheart. Okay, I'm done.